Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In this lecture, I'd like to highlight the luteal phase effect and how to understand this disease. And actually, it is with time, with many publications, this topic is dynamic and is changing regarding the definition, the diagnosis, causes, and lines of management. So, luteal phase effect is deficiency of progesterone in the luteal phase, which is the second half after ovulation. And this in the ovarian cycle. And actually, the progesterone comes from the corpus luteum, which is secreted by the theca cells under the stimulatory effect of LH to change the endometrium from non-receptive to receptive. But if no fertilization occurs, so this corpus luteum will have corpus luteolysis, and there is drop of the hormones, particularly progesterone, and so the patient will have a menstruation. But if pregnancy occurs, HCG from sensitive to plus, HCG is a surrogate of LH, can stimulate corpus luteum to continue functioning and secreting progesterone. And this function from the sensitive plus starts at 5 weeks of pregnancy and is completed at 12 to 14 weeks. After that, this work will be taken over by the placenta. So luteal phase defect is dysfunction, deficiency of progesterone, or luteal insufficiency. And actually, it is defined as clinically a clinical definition, which is luteal phase 10 days or less, or biochemically, if the luteal serum progesterone day 21, serum progesterone is 5 nanograms per milliliter or less, or combination of both clinical and biochemical. And in natural cycle, frozen embryo transfer should be 10 nanogram or less. If it is less than 10 nanogram, this is an indication to continue progesterone supplementation before embryo transfer. And previously, histologic luteal phase defect relied on the histopathologist who would diagnose it when they found the luteal phase is 2 days beyond the expected day. And actually, in recent publications and recent recommendations, we don't rely on histopathologic diagnosis. So the definition is mainly clinical, sometimes biochemical, or combination of clinical and biochemical, with special situation for frozen embryo transfer. We know that the normal luteal phase length is between 12 and 14 days. And if it is 10 days or less, this is the luteal phase defect. What about the progesterone? We know in the early follicular phase, the progesterone level is too low, 0.1 to 0.7 nanogram per milliliter, increases pre-ovulatory, but not rising up more than 1.5 nanogram per milliliter. If it rises more than 1.75 nanogram per milliliter pre-ovulatory, this is called premature progesterone rise, and this is an indication for cancellation and freeze all cycles in IVF because it has deleterious effect and decreases pregnancy rate. But in the luteal phase, the level of progesterone rises and reaches maybe 3 nanogram per milliliter, 5 nanogram per milliliter, 10 nanogram per milliliter, or more. We don't know exactly because there are variations in the level of mid-luteal progesterone, as that's why the American Society recommended 3 nanogram biochemical definition, 5 nanogram, ideally could be 10 nanogram frozen embryo transfer, 5 nanogram, because the progesterone hormone is secreted in a pulsatile form, and every day in this day it may have at least 8 to 10 figures. So there are peaks and troughs of the level of progesterone. There is no optimal level for all ladies because the menstrual cycle length is variable from one patient to another. And there is suboptimal progesterone level during the luteal phase and significant inter-individual and intra-cycle variations in regularly menstruating women. And so we cannot rely on the biochemical diagnosis of luteal phase defect we have to rely on the clinical definition, which is luteal phase 10 days or less. What about the pathophysiology? We don't have to focus on luteal phase alone, which means decreased level of progesterone, whether amount or duration, and or resistance of the endometrium to the normal level of progesterone. But we have to go back to the follicular phase and to see the FSH, LH, the estradiol, the evidence of PCOS or other ovarian problems that may alter ovulation or make defective ovulation, and this may contribute to luteal phase defect as well. That's why some studies try to predict the corpus luteum insufficiency by estimation of day 2 or day 3 estradiol. If it is high, we have to expect high level of progesterone. And also some studies try to correlate between the basal progesterone and progesterone at the time of triggering, and to find out its relation to the success of the IVF cases. Anyway, we have to not to forget the follicular phase of the menstrual cycle. How to diagnose luteal phase? I already told you it is a clinical diagnosis, relies on the menstrual cycle length, 10 days or length or less, and progesterone level as it's variable, or combination, but we don't rely on histopathologic. Some endometrial markers are used, but they are not practical and not available for all patients. Now we have a patient in our clinic. How to expect that this patient has luteal phase deficiency? We can categorize our patients into two groups, either non-infertility or infertility. Non-infertility is a good bulk of our patients in the clinics, include patients with polymenorrhea, premenstrual spotting, premenstrual bleeding, and this has a bad effect on the lifestyle of the patient, including psychological stress, social problems, religious problem, medical problem, even sometimes you may have iron deficiency, anemia, and general malaise and weakness. So we don't have to ignore non-infertility and gynecologic presentations of the luteal phase deficiency. But in cases of infertility, when we have an infertility clinic, the patients may come by unexplained infertility. Up to 10% of cases, as found in this recent study, may come with recurrent implantation failure, recurrent pregnancy loss, IVF patients, frozen embryo transfer, or some association with hyperprolactinemia, thyroid dysfunction, obesity, autoimmune diseases that may alter hypothalamic-pituitary ovarian axis. So these are the cases we have to expect that they may have luteal phase defect. What are the types of luteal phase defect? It may be idiopathic after exclusion of the causes which are secondary luteal phase defect. The causes may be follicular phase problems like polycystic ovarian disease, maybe endometriosis, maybe increased patient's age, maybe hypothalamic causes like stress, anorexia, maybe obesity, insulin resistance, maybe uterine anomalies like septum adhesions or myoma, maybe under or overactive thyroid or hyperprolactinemia, or in cases subjected to IVF exit. If we look to the thyroid dysfunction and hyperprolactinemia, they can inhibit GnRH release or secretion, and by this way lead to decreased progesterone secretion. And this thyroid dysfunction can lead to increased TSH and the hypothyroidism, and this leads to hyperprolactinemia. But hyperprolactinemia can affect the GnRH release by direct or indirect approaches. And in one recent study, up to 10% of secondary infertility patients had hyperprolactinemia. And hyperprolactinemia can inhibit corpus luteum function, can lead to endometrial dysfunction and decreased implantation as well. What is the important is the prevalence of luteal phase defect. A high prevalence of luteal phase defect among patients subjected to IVF and ICSI. So it's frequently seen in IVF. If you have a patient with IVF or ICSI, you should expect that this patient will have luteal phase defect. This may be due to the four steps of the IVF, which are pituitary downregulation in cases of long antagonist protocol, or pituitary suppression in cases of antagonist protocol. Due to controlled ovarian stimulation, ovarian triggering, and ovum pickup. So every step of the IVF EXI can lead to luteal phase defect. What about downregulation? Is used in the long agonist protocol, which means decreased number of receptors on the surface of the pituitary gland. So downregulation pituitary gland, no receptors, by this way decreased LH, and by this way decreased progesterone and luteal phase defect. In cases of antagonist protocol, the number of receptors is preserved, but there is block of the release, immediate and transient block and reversal block of these receptors. So this is by the antagonist. So this again leads to decreased pulsatile LH release. What about ovarian stimulation? We give our patients HMG, FSH, or whatever for ovarian stimulation, but they are gonadotropins, and these gonadotropins lead to production of multiple oocytes, which lead to supraphysiologic levels of ovarian hormones and suppression of LH, which is important to maintain the corpus luteum. What about triggering? Triggering are used for timed final oocyte maturation. We can use HCG, commonly we use HCG, which leads to luteal phase defect by inhibition of endogenous LH and what's called the luteal gap, which is the time between the effect of the end of effect of endogenous HCG, exogenous HCG and endogenous HCG when pregnancy occurs. And we have two types of HCG, which are urinary HCG, 5,000, but in IVF we give usually 10,000 international unit, or recombinant, which is 250 microgram or 0.25 milligram, which is equivalent to the 10,000 international unit of the urinary. Of course, recombinant is easier for application, pre-filled, can be taken by the patient herself, better dose precision, and low batch to batch variability, contamination free, better tolerated, but the urinary is cheaper, available, and can be is widely used all over the world. But the HCG is good in having a long half-life, and this will support the corpus luteum as it is a surrogate of LH. But this long effect can stimulate the follicles to release vasoactive compounds like vascular endothelial growth factor, which lead to fluid shift, which means accumulation of fluid in the interstitial space from the intravascular space, leading to ascites, hypotension, oliguria, pleural effusion, thromboembolism, and organ failure. On the other hand, we can use GnRH agonist as a trigger for the final oocyte maturation, and this has short half-life, but it leads to luteolytic effect. So the HCG is lutotrophic effect, and this is luteolytic effect. And this short half-life is good regarding avoidance of excessive and prolonged stimulation of follicles, avoiding of the ovarian hyperstimulation, but it's not good because the life span is short, so the corpus luteum will be subjected to luteolysis earlier than if we give HCG. Sometimes we can give recombinant LH, which is pure LH, and it is non-human and effective as HCG, but it's expensive and not so recommended by the ISHRI and other societies. And recently there is kisspeptin, many studies on kisspeptin as single bolus dose, which is a peptide hormone releases GnRH in the portal circulation. So these triggers can lead to luteal phase defect. So HCG can lead to luteal phase defect by inhibition of the endogenous LH and the luteal gap, as I told you, which is the gap of time between the simulated cycle between the exogenous HCG and endogenous HCG. GnRH agonist is causing luteal phase defect because of its short action. This is good and bad. Good for avoidance of inhibitor stimulation. That's why we make triggering in cases of PCOS or patients liable to very heavy stimulation or uh, antagonist protocol by the GnRH agonist, but this is bad as the electrolysis is rapid and reversible, and by this way the decrease progesterone and luteal phase effect can occur. What about the ovum pickup? We are introducing the needle to uh, penetrate the ovary and to make aspiration of the follicular fluid and aiming at taking the oocytes in this fluid. And during this aggressive maneuver to the oocyte, to the follicle, the oocyte is separated from the wall of the follicle and some separation of cumulus or forus cells which are responsible for secreting progesterone. So even ovum pickup can lead to luteal phase defect by the disruption of the cumulus or forum and decreasing progesterone. So the four steps of the IVF can lead to luteal phase defect. We have a GnRH agonist protocol, long protocol, which is down regulation, short protocol, which is flare up or ultra short. And we have GnRH antagonist. We can give GnRH antagonist either fixed dose from the 6 or 0.25 or flexible according to the size of the follicle, reaching 40 millimeter, at least 40 millimeter. We can give at day 7 or so, or single dose 3 milligram at day 7. And there are some other protocols like natural cycle protocol, but contains also ovum pickup. So the agonist protocol with HCG, we give HCG with agonist protocol. GnRH agonist trigger is never used in GnRH agonist protocol. You have to know that in this protocol, every step can lead to luteal phase defect. So the long protocol, 3.75 milligram, is causing downregulation, decrease pulsatile LH, superovulation, decrease LH again, triggering by HCG, decrease endogenous LH, luteal gap, and ovum pickup also decrease progesterone. All these steps can lead to luteal phase defect. Regarding the short protocol, starts from day 2, which is flare protocol, 0.1 milligram daily. Again, flare is not associated with downregulation, but causes superovulation, and ovum pickup and trigger again can cause the luteal phase defect. So everyone can lead to luteal phase defect, but the long protocol is more by making down regulation, which is not present in the short protocol. What about antagonist protocol? I told you the antagonists were 3 protocols: fixed protocol 0.25, flexible according to the follicular size. The largest one should be 14 millimeter, or fixed at day 7. This is causing pituitary suppression, not downregulation, suppression, which means transient, rapid, and reversible occupation of the receptors, but the number of receptors is fixed and stationary. So it leads to pituitary suppression, superovulation, triggering by GnRH agonists as premature luteolysis, and ovum pickup. So every step can lead to the luteal phase defect. Don't forget that these are recent studies on these issues. I told you the antagonist protocol blocks the receptors, but does not decrease the receptor, so it causes pituitary suppression with no initial flare-up of the GnRH agonist, and this immediate and transient is dose-dependent and rapid reversibility, so we can give GnRH trigger, agonist trigger is used, and since it is immediate and transient, we can start it late, not early in the cycle. We can start it from day 6 or day 7 in late follicular phase, because no need to use it early because it has immediate and transient effect. Moreover, if you give it early in the early follicular phase, it may have deleterious effect on the follicle itself. So the advantages of antagonist protocol: immediate pituitary suppression, low risk of variable stimulation, rapid reversible effect, short duration of action, fewer gonadotrophin injections, no adverse effect on ART outcome if given late follicular, and increased patient compliance. We can use another type of triggering, which are combination, not single hormone. We discussed single HCG, GnRH agonist, LH or kisspeptin, but we can give combination of GnRH agonist and low dose of HCG, which is paired or dual triggering one dose of GnRH agonist and 1,500 international unit 36 hours before pickup. So have the advantages of GnRH agonist and advantages of HCG, but small dose to avoid overhead stimulation. Another protocol, you can give double triggering, which is sequential. You give GnRH agonist first, and then a standard dose, HCG 5,000 at 34 hours. So the GnRH agonist 40 hours, HCG 34 hours. There is a third protocol, which is combination of urinary HCG and recombinant HCG given 39 hours prior to ovum pickup in cases of empty follicle syndrome. You can go back to the lecture on empty follicle syndrome and find these studies. So in this short introduction and discussion of luteal phase defect, I wish to highlight the importance of luteal phase defect in our practice. Don't ignore it in gynecologic cases and in infertility cases, and is frequently seen in gynecologic day practice, and it is in infertility is diagnosed in patients receiving gonadotrophins, and it's frequently diagnosed in most cases IVF, ICSI, or frozen embryo transfer. More details on how to treat will be discussed in another lecture. Thank you.